ncIMPACT is made possible by funding from Civic Federal Credit Union and is a public media North Carolina production in association with the University of North Carolina School of Government.
I'm Anita Brown-Graham. Welcome to ncIMPACT. COVID-19 is affecting our lives, our jobs, our schools. The crisis is leading us to revisit some important statewide topics that, quite frankly, require new solutions. This week, we're looking at substance use disorders. Joining us are Dr. Blake Fagan of the Mountain Area Health Education Center, Keith Arden with the Substance Treatment Program TROSA, and Dr. Dana Rice with the UNC Gillings School of Global Public Health. Our panelists have ideas to share about preventing and intervening on substance use, and they want to hear your ideas and your questions. We begin by looking at a mother's struggle after losing her son to a drug overdose. Unfortunately, there may be an increase of these tragic stories during COVID-19. This story highlights for us the need for a broad and inclusive community perspective on substance misuse. ncIMPACT's David Hurst reports.
You can just feel the love when you look at these pictures.
3 years ago, Debbie Dalton received a phone call that changed her life.
My phone rang, and it said Hunter. So I grabbed the phone and said, I was just thinking about you, and I heard this is Blake on the other end. And I knew immediately it was bad news.
Her son Hunter was 23 at the time and had recently graduated from UNC Charlotte. He was living in Raleigh, and his roommate told Hunter's mom that Hunter had been rushed to the hospital because of a drug overdose.
I just remember making a sound that didn't even sound human, and my husband had to take the phone. You know, we're trying to figure out what's happened, and rushing to Raleigh to get to our son, just get to my boy, and the whole way there just overdosed on what? You know, that just wasn't Hunter's MO.
Toxicology reports later revealed Hunter overdosed on cocaine laced with fentanyl, a dangerous synthetic opioid that is lethal even in tiny doses.
I held my son's hand for 7 days in that hospital, and he never regained consciousness, and I held his hand as he took his last breath. And just shock and heartbreak. He played soccer.
The Cornelius mother says she not only lost her only child, but also lost her best friend.
He definitely had a gift. He was very loved, and he loved back in return. And he was full of energy, loved to travel, loved adventure. He was my partner in crime and adventure. You know, we just, he lived every second. I can honestly say that.
Let's start with Dr. Blake Fagan. Blake, let's try to set the stage here. We know addiction isn't taking a break during the coronavirus pandemic, but are we seeing new trends? Are you hearing that there are more or fewer new cases?
That's a good question. This is just anecdotal. I don't have any data, as this has just been going on now for about 2.5 months. But one trend that we're seeing is that some patients who were stable and in their maintenance phase of their opiate use disorder are now destabilizing. Is that everyone? No. Was that happening to folks before? Yes. But we feel like there's a trend that they're destabilizing a little bit more. They had systems built in their life to help them in their maintenance phase. They went to work. They had their Narcotics Anonymous meeting. They had their church groups. And some of that, because of the COVID-19, they've lost their job. Maybe their Narcotics Anonymous hasn't figured out how to do it by telehealth, and so that's stopped. And we've had some of our patients that have called us and said, I'm thinking about returning to use, and others who have returned to use. So we're seeing that as a trend. Another one that we can't get a handle on, again, it's very hard to get the data this quickly, and it's hard to get to teens or minorities, but one of the number one ways that people get started into their use disorder is usually at parties or gatherings with friends, and we think that because that's not happening, that maybe new teens or young people are not experimenting as much. Those that already have a use disorder, we think, are still continuing. But those are some anecdotal trends that we think may be happening.
Well, sort of a mixed bag, some good news, bad news there. Keith, let me go to you for a second. We're starting to get some audience questions in, and Kristen and Brevard wants to know, what do you anticipate the long-term effects of the pandemic will be on substance use and mental health in our communities? What are you seeing in your work at Trost?
Well, I mean, we know that substance use disorder is a disease of isolation, and this increased levels of stress and anxiety and depression that are associated with what a lot of people are going through right now just sort of put as a dangerous combination that could certainly lead to people both outside a treatment setting and inside a treatment setting just feeling a lot of things that can lead them to become unstable, as was previously said. The thing we're concerned about, there's obviously there's some really big immediate health needs, and it's absolutely something that needs to be addressed. But we want to make sure that some ongoing societal health issues like substance use disorder and mental health aren't sort of looked past during all these times. And we want to make sure that it's not an either or proposition, but that we can continue to focus on these things and give them the attention they need moving forward, even with a lot of resources going towards, rightfully, the current pandemic.
And of course, as you and Blake have just pointed out, these things can be interrelated. It can be the pandemic that, in fact, is destabilizing people.
Absolutely.
Dana, last week we talked on our town hall a lot about telehealth and its use. I'm just wanting to throw this question from Elizabeth in Chapel Hill to you, which is, some people feel less supported and accountable using virtual services. Do you think it's more difficult to get clients to use virtual services at this time?
I think that's a good question because I think it depends. Part of it depends on if the person was already seeing someone regularly, and so if the if you start to see someone just by different mode, going from person to person, now you're using maybe your phone or using telehealth, it may be less of an awkward transition. I think we also have to keep in mind that different communities have different access to telehealth and telemedicine services or internet services, computer services, and so as much as we can do to sort of bridge the digital divide with community, I think that also sort of can help to ease the transition from sort of person-to-person contact to telehealth. But I think that this is a great opportunity for us to expand and even normalize receiving care through telemedicine and telehealth. So I think there are great opportunities, but we have to be really wary of missing people, missing communities through this new virtual interaction that we have.
Thank you, Dana. And so, Blake, some treatment has to take place in person. So what does treatment look like during a pandemic that requires physical distancing?
Yeah, so it's kind of that mixed bag of we have folks that we've really been able to help and connect to because of the telehealth, and that technology is now, frankly, being paid for, and we've ramped it up and we've built the plane while it's flying, just in the last 2 months or so, and then some of it has been not as good. So to give you an example, in the past we would have a patient that would go and they, let's say, had polysubstance use. They had multiple different use disorders, and they would go into inpatient to receive services and to go through detox for some of their things, and maybe for their fentanyl use disorder or heroin use disorder, they would get on buprenorphine and they would get stabilized. Well, at discharge, it was always a tricky little wicket where they were being discharged, and do they have enough medicine to make it to the outpatient clinic, and how do you connect to those outpatient clinics? And maybe some of the patients would not connect well, or they would return to use before they got to that clinic because their medicine would run out. And just as an example of something where telehealth has really helped is we had a patient of ours who left an inpatient stay and called us within an hour. We were on telehealth with her, scheduling her appointment and then making sure she had enough medicine to make it from that visit as she was leaving to our visit. And then she showed up for our visit. She was super grateful that we were able to give her enough medicine because she was very anxious as she was leaving the inpatient stay. She didn't know when she would be able to see us. And it didn't matter because we could connect really quickly with telehealth within an hour and say, oh, you can see us in 3 days. And we gave her 3 days of meds. So that's a win that's out there with the telehealth.
Yeah. So let me just ask you quickly. Greg in Durham has a related question, which is, how have methadone clinics in particular have had to adjust to clients during COVID-19?
Yeah, and I don't know, Keith, if you want to pick that up. I don't work at a methadone clinic. I write buprenorphine, but I can tell you some of the examples of what we've heard. But Keith?
Keith, do you want to jump in on that?
Actually, yeah, we work strictly with in a residential-based environment at Trost, but I have heard, I think that they've made adjustments to how they administer in terms of the number of days and those matters, if I'm not mistaken.
Yeah, that's what we're hearing.
Yeah.
Is that typically when you go ahead, Dana.
No, I was just going to add that SAMHSA has provided new guidelines to allow for opioid treatment and allow those facilities to dispense take-home methadone during this time so that people can continue and get more medication while they're at home, so they don't have to come out into the community and place themselves or others at risk.
Thank you all for that. For some, isolation and loneliness only worsen despair and increase the need for addiction-related services. There are organizations available for support, have been since before COVID-19. Take a look. David Hurst travels to Cabarrus County to get a first-hand view at some of these programs.
Yeah, go for it. Yeah, you're good. In the summer of 2017, Cabarrus County EMS started seeing an increase of opioid-related overdoses.
These types of calls are things we've dealt with on a regular basis. However, the volume was the problem, and we were beginning to see the impact in the community amongst families and just regular citizens as well.
The summer climaxed with 81 overdoses in August of that year, the highest number in the state. At the end of 2017, Cabarrus County EMS had responded to over 550 opioid overdose calls compared to 163 in 2016.
And so I think that we were all very surprised to find out that this was occurring in parking lots in our local shopping centers and even parking spaces in a downtown setting. And I think that's when we really became aware of how prevalent the problem was.
Cabarrus County has since been able to reduce their overdose rate. County leaders say they've been able to do this through raising awareness about the issue, as well as implementing county-wide programs intended to reduce overdoses. County leaders hosted several community conversations where discussions centered around local trends and data, dangers of opioid misuse, and information about prevention strategies. Cabarrus County EMS, along with Concord Police and Fire, carry naloxone, a medication designed to reverse the effects of an opioid overdose.
And this cabinet has a variety of resources.
Cabarrus Health Alliance also began a syringe exchange program. The No Questions Asked initiative allows people to turn in used or dirty needles in exchange for unused clean needles. The program has led to a lower hepatitis C and HIV rate across the county.
We understand that not everyone is ready for treatment. Not everyone is ready to be in recovery, but what we can do until they are ready to make that decision is make sure that they have the resources that they need to be safer and healthier.
Keith, I'm coming to you. Trost is a national model for substance misuse treatment. You run a residential operation. You employ many of your program participants. Tell us how your operations have had to change since physical distancing restrictions were put in place.
Thanks for asking. Well, a little more for those who aren't familiar. We're a full residential multi-year program. So we typically have about 450 to 500 people living at Trost at any time. We're providing comprehensive services, including housing, meals, everything that people need, all at no cost. And we've heard obviously lots of horror stories about congregate living, in settings where a lot of people are living together. Thankfully, our priority from the beginning obviously has been to keep our residents and staff safe. Thankfully, we've had no cases to date. We basically looked at it as a three-pronged approach. First, to make sure that we stayed virus-free if possible, and we've been successful with that, and then put measures in place to limit spread in the event that if we were to get a case on campus, and then finally identifying how to protect those in our community who are most vulnerable, because we have people of all ages and all sorts of health backgrounds in our community. So some of the earliest steps we had to take were things like we stopped doing visitors on campus who are non-essential. We suspended admissions for temporarily. We stopped people going to community assignments that had any outside interaction outside of TROSA face-to-face. And we worked on moving people into settings so that we could self-quarantine within the community for folks who either if anyone were to test positive, but also to make sure that we could sort of sub-quarantine, I guess, in a sense, the people in our community who are most vulnerable in the event that there was a case in the community. We could kind of put them in a much more protected situation. And we did move to telehealth, specifically with our counseling, so that people could continue to get those services even in the event that they had to be isolated and quarantined. And then a lot of our staff were working remotely for the first 2 months of this crisis.
So let me stick with you for a second, because you've got a lot of community partners in the communities where you operate. Help us understand how your engagement is working with those community partners at this moment.
Well, initially it was very challenging. A lot of it had to cease, but either because of our restrictions or the restrictions of partners in the community. For instance, a good example would be, we had folks taking GED classes with instructors from Durham Technical Community College, and obviously those things were put on hold for a while. We've started to work towards shifting how do we do these things remotely so that we can better serve our folks and also think about the long term with this. With volunteers on campus, us volunteering in the community, we basically have to, it's been tricky to navigate, and it has led to us having to pull back on certain relationships short term, and we are starting to get back into those now as we speak. Over the course of the last week or two, and in the coming month, we'll be resuming a lot more of those partnerships in a way that won't be exactly the same as it was back pre-pandemic, but at least it will resume making sure that our folks are getting the services they need, and we resume those relationships.
So, Dana, let me stick with this idea about the importance of community partners. In many of these programs, the partners are really peer support groups. So Philip in Asheville wants to know, how do you engage peer support group specialists and handle group therapy at a time like this?
Creativity. I mean, I think it's critical to understand that the community partners are really sort of the boots on the ground that help treatment programs and other public health programs really do the work and reach the community in really culturally sensitive and responsible ways. And so the community can be there to sort of augment the workforce. So they can help to help with understanding cultural differences and understand how patients interact with the health system. So I think the creativity that needs to come out, that we've already seen come out, includes really maybe connecting more, finding ways to connect more people to peer navigators and to those organizations like TROSA who are doing the work and maintain the good work that they're doing, or maintain people in community that don't have access to sort of 24-hour care. And so I think that, what they're doing as far as maintaining the relationship is key. I think in this virtual environment that we're working in, it's much harder to establish new relationships than it is to continue existing relationships. And so I think on both sides, an effort needs to be, we have to put out a real effort to maintain those relationships while also keeping an eye on, once this pandemic passes, which it will, to start building those relationships with those partners that maybe we hadn't had strong relationships with, that we have seen do service in the community.
So my guess is what the phrase many people will remember from this virtual town hall is, once the pandemic passes, which it will, because so many people are asking, will this ever end?
It will.
Let me go to you, Blake. Marcella in Cabarrus County is asking about syringe exchange programs and how we can ensure participants still receive those necessary services and resources during COVID-19. Thoughts?
Yeah, so I think there's a lot of syringe services in our communities in North Carolina. It'd always be great if there were more, but they really have worked hard to adapt. So for instance, one of the syringe services that is in my area has developed a mobile van, and you go to their website and it says which addresses they'll be at, and then they are able to give the syringes to the people that need it, along with other services like naloxone and other things in a 6-foot and appropriate manner with people wearing masks and such. So that's great that they're able to do that. So I would suggest to folks that if you have a syringe service in your area, if you will go and Google the ones that I've Googled, they talk about COVID and how they're best setting up so that they can continue to help their clients.
Wonderful. And Keith, let me give you this question, which comes up every time we talk about substance use disorders. It's a question of stigma. So Emily in Morganton wants to know, how do we work to overcome the stigma that keeps people from seeking treatment?
Well, I mean, yeah, stigma is certainly a major barrier for folks seeking treatment. And, we try at TROSA, we try to do a lot of, as an organization down to the individuals, we try to be an active, engaged member in a community, in the Durham community and the Triangle community. That's not, technically our mission is not to change people's perceptions of people in recovery, but in a lot of ways, that's just sort of the way we act is something that I think helps do that, and also instills in the folks in our program a sense of confidence that they can be a valued member of the community. That's been one of the hard things is, I mentioned that we've had to suspend a lot of our community service activities. I mean, these are things that really mean a lot to folks at TROSA, and to not be able to do that is hard, and trying to find ways in the pandemic that we can still do those things has been really important. We've been, for example, we made cloth masks for everyone at TROSA has a number of cloth masks, and we started once we kind of had our community covered. We realized we should start making some for our neighbors and for some first responders and others who didn't have access at the time, and that's been like a project that a lot of people have taken on around TROSA.
Very nice. Thank you. You know, many people diagnosed with a substance use disorder also suffer from other mental health or behavioral disorders. ncIMPACT caught up with a Granville County man who overcame his addiction and turned things around to help others.
After my playing days, I left the gym and I hurt my back. I don't actually know how I hurt my back, and I got prescribed opiates. It did something to me that I can't explain. I was physically addicted to the opiates. I've been diagnosed as bipolar. Most people who are, again, who has a mental illness, 3/4 of those people have a substance use problem, and I'm one of those people. Prior to getting clean, I was incarcerated at Pitt County Detention Center for 5 months. After my 5 months there, they asked me what I wanted to do, and I told them I wanted to go to a long-term treatment program. Went to a 2-year program in Durham, Trost in Durham, where I found my purpose, and that's helping other people like myself.
The Stepping Up initiative was started by the National Association of Counties and also NAMI in 2015, and it gives us opportunities for counties to find ways to alleviate people with mental health issues and substance use issues that are nonviolent offenders, to try to keep them out of our jails and find them proper treatment.
What we've learned from our jail administrators in this 5-county region is that they see a lot of the same people over and again, and a lot of the same people that they see in our local jails are not necessarily hardened criminals. They might need to have health care attention, and that would better serve both them individually and the community.
Going on 6 years of sobriety, I made a decision, and I act on the decision. And if I hadn't have done it, I don't think I'd be alive today. I really don't. I get up every morning and I go to bed every night with gratitude. If you can save one life, we've done a lot.
Dana, individuals with a substance use disorder are more likely to experience incarceration than those in the general population. How are the unique challenges of incarceration and substance use disorder complicated by COVID-19?
You know, I think that they're severely complicated for a variety of reasons. I mean, first and foremost, our correctional institutions have become the default mental health providers for many communities throughout the state and throughout the country. And jails and prisons really aren't the right environment to provide care for people who have mental health or substance abuse disorders. And so I think primarily we've defaulted to the wrong system to support people who need care. And then secondarily, I think the challenge is that jails, specifically in prisons, are not equipped to take on all of the measures that we know can help to prevent and mitigate the spread of this virus. And so those facilities are presented with a variety of challenges in order to, because what we know is that social isolation is virtually impossible because most facilities tend to experience some level of overcrowding. We know that they have very little access to personal protective equipment and materials to sanitize their environments. And they also have differential access to local hospitals and treatment for those who are seriously ill. So there are a variety of policy actions that I think that we can take to help mitigate the spread in jails and prisons, and also divert people who really shouldn't be going to jails and prisons in the first place to facilities or treatment programs that can help provide the care that they need.
So let me stick with you for a moment. You've outlined the challenges of people who are in jail. It is true that with COVID-19, many jails have sought to lower their population by releasing people who are convicted of or arrested for lower level crimes. What are the challenges for the folks who also need substance abuse treatments who are being let out into the community?
Yeah, so I think there's a responsibility that the correctional institutions have to connect the people that they're releasing to care. So if they're able to, if these facilities have relationships with organizations like TROSA, they're able to then make a quick connection to ensure that someone has access to care. And that may mean they might be releasing someone who has no access to telemedicine per se, and therefore there are some institutions who are providing telephones to people so that they can access that telemedicine and connect them to care. So I think that there is a responsibility that institutions have to make sure that that they're not just releasing people to the streets with no access to receive the care that they need.
So let me just stick with this issue of discharge for a moment. I want to turn to you, Keith, to ask you this question that has come in from Philip in Asheville, which is how has COVID-19 impacted the discharge plans at treatment centers like TROSA?
Well, one of the biggest complications for us at TROSA is the last stage of our program. The last 3 months are what we call workout, is folks finding employment in the community, and basically they continue to receive the support of TROSA in terms of housing and meals and transportation, but they're employed outside of TROSA in the community. And obviously during this time of crisis, job searching is not something that's really easy to do, or in many cases even possible to do. Most of the employers who have traditionally worked with us are either not hiring and in worst cases doing furloughs or laying people off. So we've had to prepare for people to do searches remotely and also extend their stay at TROSA if they need to. We're not looking at telling people, look, you've hit your 24 months at TROSA, and if you don't have a job, we're still willing to continue to let people stay at our program and continue their search for employment if that's what's necessary. In addition, for our graduates, many of our graduates go into supportive housing that we provide post-graduation, and we've been working with fee relief for all the folks who are in our graduate programs, just because of the trying times, to make sure that people don't get put in a position where they might end up in a bad spot that might lead them back towards substance use issues.
Got it. Thank you. We're getting a number of questions in around special populations. Blake, from the area of the state in which you work that transportation can often be a huge barrier for people seeking health services, no matter what they might be. So Russell in Cabarrus County wants to know, how do you see the future of telehealth in the management of substance use disorder in pregnant patients seeking prenatal care?
Yeah, and we are doing that now. So I'm a family physician that actually sees pregnant women as well for prenatal care and delivery. And then we have within our organization an OBGYN residency as well. So they are seeing folks, and they're seeing them by telehealth. And there's certain things that you actually can do by telehealth, but there's certain visits that you just have to see the patient. And so we continue to struggle with that transportation issue on the times that we do need to get them in for care. But you could imagine that we're starting to set up systems like, your next visit, if everything's going well, we're going to try to set that up to be telehealth to reduce your chance of getting into the community and potentially getting COVID. But also the patients are actually grateful that, even though gas is cheap, it's still $3, or I have to ask somebody that's not within my family unit, which means I'm going outside my germ pool, or whatever words you want to put to that, to ask somebody to drive me in. And even though we're both wearing cloth masks, I'm coming in for 45 minutes. And if I can reduce the number of those type of activities by doing telehealth for my next visit, then they're like, yeah, I'm for this. So
I'm going to stick with you and give you this question from Brandy in Greenville. Brandy's trying to figure out what would be your recommendations for individuals who have limited access to Wi-Fi, and yet their face-to-face substance use meetings have been canceled.
Yeah, this is a tough one. So within our shop, we do primary care, and then we also substance use disorder, and particularly opiate use disorder, is a basket of the care of services that we give. And so then we have behavioral health and we have peer support. So we've landed in all these different realms where some of our patients do have access to Wi-Fi and they have a smartphone or a computer, and we can see them, whether it's a provider like me or a behavioral health person or our peer support. But then some can't. They have only landlines or flip phones or not even access to that. And so we're continuing to talk with those folks and see them, we're to talk to them on the phone. And so we're doing phone services for some of those. And then some of our patients are actually, now that we're more than 2 months into this, requesting to come in. And we have our clinic set up so that it can be as safe as possible. And they're wearing masks, we're wearing masks. We're all staying 6 feet away and washing our hands or using the hand sanitizer. But there are actually some people are seeking it out. They want the human contact. They only have a phone, and they're like, can my next visit, can I come in? And we say, sure. We want them to stay safe in the harm reduction model. We don't want them to return to use. In the different harm reduction model, we don't want them to get COVID. But they have requested, and so we've said yeah and had them come in.
In some ways, this is a follow-up question. I'm going to toss this one to you, Keith. This has come in as an anonymous question. It's, how can I continue to maintain my sobriety as I, like many other people, face these tough times? Do you have some thoughts?
Sure. Well, I mean, obviously, I think it's really important to reach out to the people in your life who, if you're someone who needs help, to do your best to try to reach out. But it goes both ways. Is I think if you have people in your life who you believe need support, continue to reach out to them, continue to try to call, video chats, things of that nature, and also pay attention to, changes in, their activity in certain ways. And also there's definitely online groups that have popped up, and I think it's something that actually, could potentially in the long term be a benefit, is that, people aren't always in a place physically where they can get to different groups and meetings and things like that, whatever works to support them. But I think a lot more virtual options will be out there and be with us to stay, I think, even after we move on from this pandemic.
Thank you. Dana, next question for you. It's coming from Jade and Carrie. And the question is, how would you advise providers to evaluate the efficacy of telehealth for substance use disorders?
That's a great question. And I actually think that it might be a little bit too early to evaluate the efforts that are being made right now, because we're currently in this reactive cycle where we're trying to provide, or providers are trying to deliver the best care that they can quickly and effectively. And so I think that once we get to a more stable environment, where I do think that telemedicine, since we've now taken this leap, we're not going back, and to kind of pre-telemedicine days. And so I think that will allow more opportunity for us to be really thoughtful about how to measure effectiveness of these new technological interventions.
And let me stay with you for a second. So this question came in from Anita, and it wasn't me because I've been talking to you, so. The question is whether there are disparities in treatments in the medical community, from the judicial community, for people who are suffering from opioids versus people who are suffering from addictions to crack cocaine.
So I think that there are a couple of questions in there, and I think in general, the first question would be, do disparities exist? And I would say absolutely. It's not, and So what I'll say is that I think what we know is that people of color, African Americans, Latinx communities don't necessarily use drugs, just the broad category, or alcohol, more than their white counterparts. What I think that we're seeing, though, is they have disparate or less access to care and services. And so there are many more people outside of that care network that are people of color than our white counterparts. And so what that has created is essentially a vacuum of services where they're not able to reach the people who most need the care. And so I think that with these efforts, we need to definitely target services to communities in need, so that we can start closing that gap and create more equity in the care that's provided to community.
And Blake, I noticed you nod in your head. Do you want to jump in on this?
Yeah, if I could go off what Dana said, the other is they definitely have all those things. So they have less access to services, but even if they have the access, the other piece that I think I've discovered over my journey of helping people with substance use disorders is sometimes they're just distrustful of the system, and I look like the system. And so what we've tried to do and what we need to do across North Carolina is get people that look like them to be the ones that reach out to them. I can ultimately be the one that maybe provides the buprenorphine or help to connect them to counseling services, but we need more of our peer support specialists. We need more of our behavioral health folks, and frankly, more of our providers that look like them. And then I think they'll be a little bit more trusting of the system. But I just wanted to put that one little piece in there. I think that even if the services are there, sometimes they're not utilizing them. And me and my naivety at the beginning of all this journey for me was like, well, why not? And then I found out, well, they've interacted with the system before, and they've been put down, they've had a negative interaction, and so even though the services may be there, they're not reaching out. So we have to be active and reach out to them with people that frankly look like them.
Let me stick with you for this next question, Blake. It's coming from Terry. I started by asking you about trends. The specific question here, though, is whether the overdose numbers have been going up in the last month.
That's a great question. I have not seen the data from North Carolina Department of Health and Human Services. They have a violence and injury prevention branch that runs those numbers. My suspicion was this. This is again just total anecdotal. Is that from talking to our patients is that when the COVID first started, the reaction to the anxiety of it, and then losing your job, and then being put back into situations like with your family, if you're LGBTQ and your family doesn't necessarily accept you, was that with that increased anxiety that people maybe were returning to use or using more, or my suspicion was we might have had some increase in overdoses, but I don't know where that trend is now. I don't know if Keith or Dana have any data.
No,
I haven't seen the data yet.
It might just be too early.
Yes.
Yeah.
On the other hand, this next question that comes from Tony, there's plenty of data about. This question is, has there been an upward trend in alcohol sales since COVID-19? Anybody want to take that?
I'm not sure.
Let's just say
I would say preliminarily, I believe so.
Yeah, the newspapers seem to suggest that ABC stores are reporting a significant upward tick.
Yes, that's what I'm hearing from the papers, but then also from patients and everyone. Yeah.
Yeah. Another question from Anita on Facebook. Will North Carolina create legislation that removes criminalization of any addiction as a crime? Any thoughts about that, Keith?
You know, I'm not sure where that will go, but I mean, it's definitely something that's on people's minds. I mean, certainly over the last few years, I feel like there's been a shift towards trying to help people get treatment rather than incarcerate. I think it's something that, you know, we still have a lot of work to do on, but I do feel like there has been a bit of a shift over the last several years. And I do hope that as a society and as a state, we continue to look at drawing a distinction between crime and a chronic disease and people who really just need help. And incarceration is not a solution, and it's not something that's going to cure people or help people in that who are struggling with mental health and substance use disorders.
So Dana's been giving you a lot of nods during your answer. Dana, do you want to jump in on this?
Yeah, I just want to add that, incarceration has actually been one of the least effective tools for treating, preventing substance use or treating mental illness. And so it's definitely something that I hope we move away from in the future. Whether that's feasible and possible in this current political climate, I'm not sure, but I do agree that we've definitely seen more conversation around treating medical conditions as medical conditions and not criminal justice issues. I think that programs, we watched a clip from Granville Vance, and they are, I think, a good example of a community that's using alternatives to incarceration for people with who are dually diagnosed or who have substance abuse or mental illness issues through their Stepping Up initiative. And I think that is an example of where stakeholders, including police and correctional institutions, along with community partners and providers, have come together to both first understand the issue of mental illness, understand the issue of substance abuse, and really get that it's not really an issue that can be addressed through criminal justice response. And they've worked together to really divert people from entering into the correctional institution into care facilities by connecting, by being that bridge to connection. They've made changes with their police policies to sort of reduce the number of arrests and help the police make decisions, sort of use their discretion better to help divert people to care rather than into the correctional institution. And we also know that it's cost saving, right? So I think that there are definitely better tools to redirect folks from care, from incarceration to care, but whether that's possible in this current climate in the way that it needs to be done, I'm not sure.
Thank you. Let me toss this next question to you, Blake. It's coming in from Facebook. Has North Carolina implemented the new federal guidelines for outpatient clinics distributing medicine on a regular take-home basis?
So I believe so. If what they're saying is that in the past we had certain medicines that we call controlled substances, and they had to be that patient then had to be seen in a certain time frame, like once a month or once every 3 months or something to that effect. And the federal guidelines have come down, and North Carolina has adopted them that to try to reduce the chance of a patient getting COVID, we can now give a longer prescription. So if that's what they mean, yes, we have adopted those.
And this next question, I'll start with you, Blake. It goes back to the point that you were making earlier. So this is coming in from Facebook from Wanda. And the question is, how do you help ensure the diversity of providers or folks that reach out to engage those impacted?
Yeah, so that is a tough question. It's an easy question. It's a tough answer to get. So if you were to look just like, say, at physicians, we believe that to get people of color to get through medical school and become a physician who then stays in North Carolina and practices in areas that we need them, is we probably have to reach back to middle school and make connections with people there and in high school, because you can imagine that if no one is even talking to certain folks about, hey, have you thought about a career in healthcare, that this doesn't even enter their mind then. But if they have a mentor or somebody that's meeting with their classes or meeting even in small groups or individually and encouraging, hey, have you thought about being a pharmacist, a dentist, a public health official, a physician, and they hear that over and over again from middle school through high school, they're more likely then to maybe choose a career in that area. So it is a long pipeline. We talk about it, and we're trying to reach back in the pipeline and trying to encourage folks, such as the minority mentoring program that we have, that each year we're adding, it seems like, more people to it from our local high schools, and really trying to encourage folks to develop their inquisitiveness about careers in medicine.
Dana, as someone who's in the business of educating public health students, do you want to weigh in on this?
Yeah, I mean, I would completely agree that pipeline programs are critically important. The earlier we start introducing health professions and helping professions, careers to students of color, the earlier you can develop their interest. I think there also needs to be support for helping to financially support these students who have an interest. I also think that we also need to sort of expand the scope of practice into all of the helping professions, but it's absolutely critical to make sure that we reach students early, we connect them to people that look like them, that can offer mentoring, and it's hard to be what you can't see. And so I think that that's critically important tool, but there are a lot of steps along the way that need to occur if we're going to really see an increase in minority representation in the medical and public health professions.
Thank you. Keith, this next question is specifically for you. It's from Mike on Facebook. What are the numbers telling you with regard to how many start and how many complete the Trost program?
Thanks for asking. So we have, over the course of the last, since the beginning, we've been keeping numbers. We typically see about 1 in 4 people complete a full 2-year program. It's really hard to compare us to a lot of programs, but we do know nationally that completion rates for short-term treatment, and that's 30 days or less, hover around 50%. And completion, or the median length of stay is another thing we look at, and median length of stay at Trost tends to be in the 7.5 to 8 month range, and nationally it's much closer to 2 months. So, we know that there's a correlation between length of stay and long-term success. We're always working on pushing that median length of stay longer. If we can just keep people another month or two, we know that each month that a person is at Trost decreases the likelihood of them having either a relapse, or even more importantly, even just criminal recidivism and things of that nature. There have been independent studies done on the criminal recidivism for folks at Trost and people who have been with us for just a few days versus people who have been with us for 6 months, a year, 2 years. And there is, the more people stay at Trost, the less likely they are to be rearrested.
Which makes a lot of sense. Yeah. More intensive services over time. These questions that are coming in are amazing. I'm not sure who to toss this next one to, so jump in. This is from Marianne on Facebook. Any advice about working with people who are homeless?
I'll jump in then. I think the homeless population, so first of all, I think that we're all starting to realize that we're all in this together, right? And even in other countries, they've noticed this. If I can just riff off for just a second, Singapore shut this thing down, and they had it airtight, and then it sprung back up again. I'm talking about the COVID, and where it did was the people that were marginalized in their communities. And so the same thing is that we're all learning that folks that are jail involved and folks that are experiencing homelessness, that they are more likely to be in tight groups, or maybe not doing the social distancing, maybe not be able to find a mask or what have you, and then they get it. But it's not just them. Then they can spread it to the rest of the community. So we all have to decide as a community, we have to take care of everyone. And so I think each county, each region has different services that are set up. In our county, they are monitoring the homeless population, and if they are found to be COVID positive, they're actually temporarily housing them and then making sure that they connect to medical services during that stay to make sure that they don't get worse. And if they do, then obviously we're moving them on to the emergency department or for admission to the hospital. But so that's one county's response in Buncombe County. But I think probably each county is trying to handle this differently, but we have to handle it.
I absolutely agree. I just want to chime in and say that if we don't take care of the marginalized, and I think this pandemic has really shined a bright light on how we've left so many behind, then we're all at risk. And so it's definitely our responsibility to make sure that we take care of those who are most vulnerable. And there have been plenty of examples. I mean, I think that that's a great example of what's happening in Buncombe County, San Francisco, California, those regions that have high rates of people who are experiencing homelessness have done very similar things to great success. And so I think there are several models out there that that are available to us, but to your point, they do have to be tailored to the community and the resources that are available in the community. I just think we have a responsibility to take care of each other in this time.
So Keith, I'm going to toss the last question to you. We've been talking a lot about treatment, and treatment is your business. Any advice on prevention during COVID-19?
Oh, wow. Well, I think it kind of goes back to a lot of the just maintaining these relationships we have and making sure that, people in your life don't just sort of fall by the wayside, that you're reaching out and being really proactive about trying to talk to the people in your life and connect to the people. And if you're someone who needs help, not being afraid to reach out to who's out there for you. And really just paying attention to how the people that you know and that you love are responding to things. And if you notice changes, that you say something about it and that you address it and don't just let it slip by.
Wonderful. Keith, Blake, Dana, I can't thank you enough for being with us today and sharing such great insights into a situation that was troubling before COVID-19, but has gotten so much more complicated as a result of. This has been very, very helpful. Thank you for watching and engaging. When we work together, we find new solutions, always, even in the face of COVID-19. If you think of a solution or have a comment, visit unctv.org/ncIMPACT. I'm Anita Brown-Graham. This is ncIMPACT.